morning, everybody. So it's my pleasure to take part in this prestigious conference regarding obstetric anesthesia and taking care about pregnant women. So my topic for today is neurosurgery during pregnancy. Uh, I'm Professor Udin Dome from Faculty of Medicine, University of Medicine in Tirana. Nothing to declare at all. Regarding incidence of neurosurgical procedures during pregnancy, brain tumors in pregnant women ranges between 3.6 per million or 3 new cases in 100,000 patient. Vascular lesions in pregnant women is a range about 0.01 till 0.05%. And elective surgery should be, if it's possible, should be postponed 6 or 8 weeks after the delivery. As everybody knows, everybody who is taking care about pregnant women in non-obstetric surgery and obstetric surgery as well, you know that there are some specific hemodynamic changes in normal pregnancy. The cardiac output is increased, the mean blood pressure or the mean arterial blood pressure has a tendency to be decreased due to vasodilatation in pregnant women, and of course a drastic reduce of systemic vascular resistance that can be associated with the cardiac hypotension in pregnant women. Pregnant woman can increase her the weight during the pregnancy, and so changes in ventilation are often seen during pregnancy. So the basal metabolism is increased, the oxygen uptake is increased, the minute ventilation is increased, perhaps the functional residual capacity may be decreased, that make a pregnant woman more susceptible to hypoxia and to atelectasis or postoperative atelectasis. As well, there are changes in total blood volume, plasma volume, and red cell volume in normal pregnancy. So total volume tends to increase, not so parallel with plasma volume, and of course not so parallel with red blood volume. So we face in every woman, in every pregnant woman, we faced a little bit of anemia, hemodilution. So the increase of total blood volume is not associated with an increase with red blood cell volume as well. There are very specific data regarding how the baby is going to grow up and to be formed in mother's uterus. So as you see in this slide extrapolated from up to date, you can see that between the weeks we can see the development of central nervous system, heart, ears, eyes, limbs, teeth, and so far. And this is very important to take in consideration in which, let's say, age of pregnancy the woman is when she was when she's presented to neurosurgery or to non-obstetric surgery as well. Nevertheless, neurosurgery during pregnancy has some specific characteristics. So, for example, eightfold increase in airway complications in pregnant woman patients as compared with non-pregnant. Hyperventilation and acute respiratory alkalosis has been shown to decrease fetal oxygenation due to left shift oxyhemoglobin desensitizing curve. And we have to maintain, let's say, and at least the CO2, PA CO2 between 25-30 millimeter of mercury scale. Of course, emergency hypertension should be aggressively treated due to increased potential for hypertensive urgency or emergency. Another article regarding anesthesia for a chapter in the book regarding anesthesia for neurosurgery in the pregnant woman, we can see that let's say in major lines there is the same like in non-pregnant women, but with some specific, for example, with aspiration prophylaxis, left uterine displacement to avoid autocaval compression, adequate pre-oxygenation, and of course propofol, fentanyl, and lidocaine or rocuronium to facilitate the muscle relaxation. And taking care with mass ventilation and quick pressure, so rapid induction, in order to prevent the aspiration. Besides the let's say the prevention, pharmacologically prevention with non-particular acid or metoclopramide or omeprazole or ondansetron. But this paper published in Surgical Neurology International, so neurological emergencies during pregnancy, management dilemmas. It's an article published in 2023. They stated, so the author stated that mannitol causes a hyperosmotic state in the fetus, leading to dehydration. Anti-seizure medication are teratogenic, and probably Keppra, levetiracetam, is the most safe in opinion. Endovenous anesthetic and local anesthetic may be safe. Cranial procedures can be performed only under general anesthesia. And of course, during the surgery, monitoring fetal heart rate and maternal uterine contraction are mandatory. In prone position, take care about the position and the paddles. Radiation level for teratogenic risk is more than 0.05 unit with the highest risk in the first trimester. And CT scan may be an alternative, may be rapid, available, and sensitive in order to diagnose some intracranial problems in the pregnant woman. This wonderful book regarding neuroanesthesia states that probably anesthetic maintenance for craniotomy in the pregnant woman may be composed by fentanyl, isoflurane, non-depolarizing muscle relaxants, and propofol for tight brain. But this depends on protocol of own institution protocols, and of course availability of the drugs, and how the anesthesia team has let's say experience or not. I'm going to present to you 3 cases. So 2 cases were published in accepted for poster publication in European Congress of Anesthesia and Intensive Care, so ASAIC Society. The first case is a spinal tumor. The lady was 21 years old lady in 29 week of pregnancy, who was verified by imaging spinal tumor in T10 spreading or going to L1 lumbar, the first lumbar vertebra, and of course with very severe progressive neurologic deficits to the legs. So we just collected all the data, and a multidimensional team, including neurosurgeons, neurologists, neonates, obstetrician, and of course anesthesiologists, were involved to guarantee the safety of the procedure. Of course, before the surgery, we just begin betamethasone, nifedipine, and magnesium sulfate in order to prevent miscarriage and to prepare the baby's lung if delivery was going to do. A careful position of the lady in operating theater, in operating bed, and online all the time. Perioperative time, so pre, intra, and postoperative fetal monitoring. The baby was well and is delivered in term after this procedure. So let's say approximately 14 weeks later. The second case is a case that he was presented with big olfactory meningioma in one young lady, pregnant young lady, 25 years old, in 33 week of pregnancy. We proposed her to deliver the baby, but she refused. So she undergo to neurosurgery to remove big olfactory meningioma when pregnant in the same time. So in this case, we try to to ensure better conditions for neurosurgeons. So not to have brain edema. So not to have hypotension. To keep in mind all the principles of neurosurgical of anesthesia for neurosurgical tumors, for intracranial tumors, and of course to take care about the baby. So in general, for the neurosurgeon to maintain a brain without edema and to avoid hypotension, but at the same time avoiding hypotension, it was useful for the baby too. Of course, we just practice as let's say as institute protocol the use of betamethasone, nifedipine, and magnesium sulfate in order to prepare the baby or to lower the risk of miscarriage. And the procedure was was done perfectly without any problematic and uneventful. And the patient was discharged from operating room to ward, taken care by the neurosurgeons and of course by the obstetricians. The third case that was right yesterday, there's a lady, pregnant lady. She came from United States here in Albania. She suffered a previous idiopathic ischemic spinal lesions before 1 year ago, and right in the moment of presented for C-section, she was with sinister hemiparesis. So sinister hemiparetic, and she was going to deliver the baby. So, but before the surgery was verified a knot in the umbilical cordon. So the lady was, let's say, forced to go to C-section. But what kind of anesthesia do we prefer? So we just consulted the case, and we avoid spinal or epidural anesthesia in order not to further or at least hypothetically damage or further damage of sinister hemiparesis. And so we decided to go under general anesthesia without muscle relaxants. And during the general anesthesia, we maintain a mean arterial pressure 70 to 80 millimeter of mercury scale by using invasive blood pressure monitoring in order to ensure that the spinal cord was hemodynamically stable and was, let's say, better perfusion with blood. This is the video that where the obstetrician is just taking care or trying to explain the knots in cordon umbilical. So the principles of let's say the non-obstetric anesthesia during pregnancy includes that probably a pregnant woman should be never denied indicated surgery regardless of trimester. If possible, non-urgent surgery should be postponed, or elective surgery should be postponed after let's say delivery. No current anesthetic agents has been shown to have any teratogic effects in humans, but of course we prefer to avoid all the unnecessary procedure and drugs. A hallmark of taking care about this kind of combinations of pregnant women for neurosurgical procedures is fetal heart rate monitoring by obstetricians, and the surgery in the final, but not with at least important, is that surgery should be done in institution with neonatal and pediatric services, with good anesthesia team, with neurosurgery, of course, and we well prepared obstetrician, physician, and team. A qualified individual should be readily available to interpret the fetal heart rate patterns in order to detect as soon as possible any changes that will be detrimental for the fetus stain. In the first trimester, the teratogenic effects of the drug. The second trimester are miscarriage is of great importance and of great concern. And in third trimester is, of course, preparatory delivery. So regarding the age of the pregnancy, the stage of the pregnancy, we have to decide about our anesthetic plan to take care about this woman. So, as conclusion messages are: pregnancy during pregnancy presents neurosurgery during pregnancy presents a big challenge. Anesthesiologists must take in consideration pregnancy and neurosurgical procedures. So, all the principles of treating of the patient, and to make a detailed anesthetic plan in order to ensure the safety of neurosurgical procedure, but of course the safety of the mother, the patient, and the baby. And this can be done, of course, by a multidisciplinary team in order to further guarantee the success or to further improve the patient prognosis. Thank you very much for the invitation. Thank you to Professor Borislava Puic for the invitation, and I'm so happy to take part in this event that and have the possibility to exchange our ideas and experiences. Thank you very much.